EECP uses the vascular beds in the body's lower extremities to boost cardiac function. During diastole, a series of inflatable cuffs apply pressure to the vascular beds in the calves, lower thighs, and upper thighs, including the buttocks. The cuffs inflate in sequence, beginning with those most distal to the heart and proceeding to the proximal cuff, so that blood is moved towards the heart without creating a bottleneck effect. The pressure of the inflated cuffs returns both arterial and venous blood to the heart. Then, immediately before systole, the cuffs deflate, causing a rapid drop in vascular resistance. This results in a decrease in cardiac afterload. The immediate effect of EECP can be seen on the EECP monitor. As EECP is initiated, diastolic pressure can more than double.
When any treatment, particularly for heart disease, has a long history, but there's no real study that evaluates it in a scientific fashion, there are still questions about it. The MUST ECP study was performed to validate the breadth of clinical experience that suggested that the device could dramatically reduce angina and improve the quality of life of patients with coronary artery disease. The patient inclusion criteria for MUST ECP were the similar as used in other trials evaluating treatments for coronary artery disease. Patients had to have angina pectoris, they had to have proof of coronary artery disease, and they had to have an exercise test positive for ischemia.
There was two arms to the study, a treatment arm where patients got full EECP counterpulsation, and a sham arm where patients were actually put into the device and had a counterpulsation mechanism actuated, but no real effective counterpulsation was delivered.
So the patients still thought they were getting the treatment. They couldn't distinguish whether it was the effective therapeutic pressure or the sham pressure.
The outcomes of the MUST EECP study were measured primarily by the stress test results. Those were all sent to a core lab. The exercise treadmill strips were actually measured at the core lab in a blinded fashion, and then the data entered and given to statisticians. There was an improvement in the total exercise time as well as the time to ST segment depression.
When one looks at the data in MUST ECP in over 130 patients who received the treatment, the number of dropouts for patients not able to tolerate the device was actually quite small.
Well, when we look at the patients who went through the treatment protocol, it was very, very well tolerated. Our own experience here saw patients universally go through the protocol with no difficulty. Most of them watched TV and read magazines. Some of them slept during the treatment. And so as any discomfort, we saw almost none.
To summarize, here are the data on the three principal outcome measures of MUST EECP. Exercise duration. With exercise duration, we found that both groups improved significantly from baseline. The EECP group about twice as much as the sham group. Time to exercise-induced ischemia, the most objective measure. EECP treatment resulted in highly significant improvement from baseline, while there was no change in the sham group. The difference between the two groups was significant, with a p-value of 0.01. Weekly anginal episodes. EECP produced a significant decrease in this measure starting at week 3 and continuing to the end of the trial.
The results of MUST EECP were quite extraordinary in view of the fact that the patients were actually quite ill from their heart disease when they entered the trial. For instance, a majority of the patients had had prior heart attacks, many of them had had prior bypass surgery and angioplasty, and a majority of the patients also were on more than 1 or 2 medicines at the beginning of the trial and left on them. So actually, these results have to be really looked at in the context of a group of patients in whom other treatments had been exhausted. We have now demonstrated in MUST ECP that the device works in reducing angina, and ECP can now be offered to qualified patients instead of invasive procedures such as angioplasty and bypass surgery.
EECP has 3 distinct acute effects on cardiac function. First, because the retrograde aortic blood flow produced arrives at the heart just when the heart relaxes, at the precise moment of the inception of diastole, there is an increase in coronary perfusion pressure and flow. Second, because pressure on the lower body vascular bed is released just before contraction, there is an immediate drop in peripheral vascular resistance, resulting in decreased afterload. Third, The combined effects of decreased afterload and increased venous return results in increased cardiac output without an increase in cardiac oxygen consumption. When stenosis or obstruction occurs in a coronary artery, the myocardium served by that artery and its associated vasculature becomes ischemic and may become necrotic. Patients with angina who receive EECP have demonstrated chronic benefit consisting in increased capacity for exercise with less ischemia. A suggested mechanism of action for this chronic effect is that the increased coronary perfusion that results from the retrograde blood flow produced by EECP favors the development of collateral vascularization. When the blood flow in a coronary artery is reduced, a pressure differential develops between normally perfused myocardium, labeled P1, and ischemic myocardium, labeled P2. During EECP, peak diastolic pressure may increase to 150 millimeters of mercury or more, thereby increasing the pressure differential. The increased perfusion pressure differential promotes the formation or widening of collateral vessels in the myocardium, reversing the ischemic process and producing the observed benefits.
I think the short-term benefits of EECP come from simply reducing afterload and improving diastolic flow and augmentation and increasing venous return. And you can see that acutely when you study a patient who's receiving EECP for the first time. I think what's less clear is why we see the chronic benefits, why after 35 treatments patients feel better and are able to have much better functional capacity. They're able to walk a greater distance, they're able to exert themselves for a longer period of time without having their symptoms of angina. We don't know why the benefits are seen long-term after ECP, but I think there's some very interesting explanations based on recent scientific data. It's been recently shown that if you take endothelial cells from the vasculature and expose them to stress or strain, that they will release growth factors. It's also been very recently shown that if you take the coronary vasculature and expose it to these very same growth factors, either giving the protein or giving an adenoviral vector that will overexpress that protein chronically in the vasculature, there's a marked increase in angiogenesis. So if one fits the two pieces of information together, one can hypothesize quite rationally that the increased stress on the vasculature that occurs with the marked augmentation in diastolic flow is converted to a release of growth factors by the stretched endothelial cells, which in turn causes angiogenesis and the increased development of collaterals.